for this webinar. The topic today was step-by-step transcatheter aortic valve replacement. So what I've decided is I'm going to show you a live case which I've recorded, and this will also explain step-by-step deployment and use of Myval, which is a transcatheter heart valve. So without wasting any further time, we're going to start this. Just a few introduction, a few slides about the Myval. So Myval is a balloon expandable transcatheter heart valve. It has a nickel cobalt alloy frame. The leaflets are made of bovine pericardium leaflets. There is an outer skirt to prevent the paravalvular leak. The upper half of the valve frame is open cell so that the coronary ostia are not obstructed. The lower half of the frame is a closed cell which gives good radial strength, and the outer PET buffing prevents the paravalvular leak. It comes in 20, 23, 26, and 29 mm sizes. There are some intermediate sizes as well, 21.5, 24.5, 27.5, and some extra large sizes, which is 32. So how the valve is delivered? The valve is crimped over a balloon. Balloon has a proximal and distal stopper. The valve is directly crimped over the balloon. The crimped valve is advanced through the Python sheath, which is an expandable sheath. So all sizes go through a 14 French sheath. The 14 French sheath expands to the size required for the valve, which is going across into the sheath. And once the valve is delivered, the sheath comes back to a lower profile. The advantage of this sheath is, suppose you're not able to cross with the valve or you're not able to deploy the valve, it can come back into the sheath and out of the body. So the advantage compared to other balloon expandable valves is that two sizes of sheaths are not required. Everything goes through a single size. So how the valve is delivered? The valve is crimped over a delivery catheter, which is called Navigator catheter. The Navigator catheter has a balloon distally, which has a proximal stopper, a distal stopper, and indentation in between where the valve is crimped. And you can see there's a rotating handle at the proximal part. So what does the rotating handle do is, as we rotate, you can see how the distal end of the catheter flexes. The advantage is the valve can negotiate easily across the tortuous anatomy and also in a very horizontal aorta. The balloon, as you can see, once we deploy the valve, there will be a dog boning which develops. And because of that dog boning, the valve remains very stable. This is another example of the Navigator catheter where you can flex. So as we flex, you see the distal tip can bend on itself and the valve can negotiate easily through a very tortuous anatomy. This is very important in horizontal aorta and also in patients who have tortuous descending thoracic aorta as well as ascending aorta. This is the whole spectrum of clinical program for the Myval. We have already completed the first in man study. The first in man study of 30 patients was published at Euro PCR, and now the 100 patient data will be presented again at Euro PCR next month, which is an online conference, and the data has been submitted for publication in Euro Intervention. The average age of the patients was 75. 73% were male. The average STS score was 6.4. And this is the data from the first in man 30 patients. These are the valve sizes which were used in these patients: 20, 23, 26, and 29. You see the majority of patients received 23 and 26 millimeter valve. Pre-dilatation was mandatory in almost all patients. The baseline echo gradient was 47.4, which decreased to 5.8 post-procedure. The peak gradient was 71, which decreased to 8 post-procedure. Velocity 4.4, which decreased to 1.8. EF improved from 45 to 47%. There was no severe aortic regurgitation post-procedure. The two patients had mild paravalvular leak post-procedure, which remained at mild at 30 days. However, at 1 year, even this mild had disappeared. And this is the all-cause mortality. My comparison with other trials, the all-cause mortality was seen in 2 patients at 30 days, and 1 patient had peripheral arterial complication, and died from renal failure. This we already discussed. What is the advantages of Myval? Upon crimping, the Myval gives a precise V-shaped alternating dark and light band. So you can see in this picture, there's a dark band, there's a light band, there's a second dark band. And this is how the valve is positioned across the annulus, and in such a way that the level of the second dark band, middle part or lower part of the second dark band, is at the level of annulus plane. This precise positioning of the valve allows the valve to be positioned higher into the LVOT and prevents pacemaker implantation and complete heart block. So let us look at this patient which I'm going to show you in this recorded case. So how a valve, this is a 77-year-old patient, severe aortic stenosis, NYHA class 3 and 4, and how the valve is sized. The valve is sized based on the CT scan. So you see this is the CT scan report where we measure the annulus of the aortic valve, we measure the diameter of the aortic valve, we measure the perimeter of the aortic valve. So you can see this picture again. You see the annulus which has been measured on the CT scan of the annulus, LVOT, and the ascending aorta, and this also shows the calcification. So I'm not going to go into detail, but this is just for information that the transcatheter aortic valve is sized based on the CT scan assessment of the annulus, LVOT, and we also calculate the coronary height in order to prevent the coronary occlusion. We also calculate the angle of implantation at which the angle will be implanted. The second is we also need to look at the dimensions of the femoral artery, the calcification in the pelvic vessels, and the tortuosity in the pelvic vessels. That is important because in order to do a transfemoral TAVR, the femoral artery size should be of adequate size so that the sheath can go in and there is no damage to the pelvic vessels. So just for stressing that it is the transfemoral TAVR which was statistically superior than surgical aortic valve replacement in partner 2 trial. So I would try to do all the TAVRs through the femoral artery by a percutaneous approach and no surgical cut down so that the patient's recovery is faster and the outcome is faster. So this is a pigtail catheter which goes from the femoral artery into the non-coronary cusp of the annulus. And here you can see is a temporary pacemaker which comes from the IVC, goes to the RA and the RV, and this is the tip of the temporary pacemaker. So what is the annulus? For the surgeons, a surgeon would see the annulus right in front of the eyes when he opens the aorta. But here for us, the annulus is a nadir of all three cusps in a straight line. So you see, this is very important. We need to identify this is the left coronary cusp, this is the right coronary cusp, and this is the non-coronary cusp. So these three cusps are clearly seen on the angiography. And then we also assess the leakage, aortic regurgitation, if any. You can also see that this patient has a very severe mitral annular calcification. So this patient is actually very high risk for surgery as well as high risk for TAVR as well because of the calcium into the mitral annulus and also calcium in the leaflets. So the next step is, let me just go. Next step is crossing of the valve. So how do we cross the valve? We would cross the valve using an AL1 catheter and a straight tip wire. Once that is done, you can see here is a catheter. We would place a wire again to the left ventricle and the catheter will come out. So because we have to do TAVI over a very stiff wire, on this wire I would place a pigtail catheter. A pigtail catheter would enter into the left ventricle. Now, if you can see, there is no endotracheal tube in this patient. The entire procedure is being done under conscious sedation. That means no general anesthesia is being used, no transesophageal echo is being used, and post-procedure we can do an immediate neurological assessment in this patient to make sure there is no stroke which is happening. So once the wire is put in the left ventricle. So what we have done now is I have advanced the wire across the stenosed aortic valve. This is a very vital step where we need to cross the valve with a wire and a catheter. Once that is done, then on the wire we would advance a pigtail. So you would see a pigtail catheter will be advanced on the wire and The reason we need to advance a pigtail catheter is we need to do the hemodynamics. So I'm waiting, I'm trying to catch up with the procedure which I'm doing. So now you can see two pigtail catheters in the heart. One is above the aortic valve, which is in the ascending aorta, and one catheter is in the left ventricle. The advantage is now I will be doing a hemodynamic assessment. So I will make sure that this patient has severe aortic stenosis, and also I would measure the aortic regurgitation and LV-EDP in this patient. So I would measure the blood pressure from a pigtail which is there in the LV, and also from a pigtail which is there in the ascending aorta. So the pressure difference from these two catheters will give the severity of aortic stenosis by measuring the peak gradient, mean gradient. So on your bottom frame, you can also see a transthoracic echo which is being done. And what we are trying to look at is whether the pigtail is caught in any papillary muscle and what is the location of the pigtail. And I'm just waiting for them to show the hemodynamics so that we can see the pressure difference between the LV and the ascending aorta. And so you can, if you can appreciate on the echo as well, the valve is heavily calcified and the opening is restricted. So you can see that in a 5-chamber view. And once now you can see the pressure difference. So you see peak to peak, there is a difference between the LV and the ascending aorta. But however, there is no aortic regurgitation and the LV EDP is around 10. So what you can do in such patients who have low LV EDP is we can give some extra fluid and prevent contrast-induced nephropathy. Once that is done, now the wire which I'm advancing is a stiff wire. So the stiff wire is always advanced in the ventricle inside a pigtail. So you would see the pigtail is there and I will be advancing a stiff wire inside the left ventricle. The reason is pigtail protects the left ventricle from any damage which a stiff wire can do. So if I would advance a stiff wire without a pigtail protection, this wire can cause perforation in the left ventricle, interfere with the papillary muscle, and also interfere with the mitral valve. So you can see on the echo, I'm confirming the position of the the wire. For those who are interested, on the right side, you can see the wire is there in the cavity and going to the apex. That's very important. So if the wire is on the lateral wall of the heart, there is a high chance of free wall rupture. So once the wire is positioned and wire is at the right uh, spot, next is I'll be doing a pre-dilatation. So what is a pre-dilatation? You can see here on the hands, I'm advancing a balloon. So the balloon goes over a wire and the balloon will go inside the heart across the valve. So pre-dilatation is required so that we can, the valve, when I'm advancing the valve across the annulus, it does not find any resistance and can go smoothly. The other thing is this is a very horizontal LV. That is the reason is if you see the level of pigtail, which is there in the aorta and the wire in the LV, they both are at the same level. Now the balloon is advanced. So you see the balloon which goes in. I'm going to position the balloon across the aortic annulus. So how to dilate an aortic valve? It is different from dilating a mitral valve or a tricuspid valve. Remember, this is a very high pressure area and the difference between the LV and the ascending aorta is high. So I'm going to do a rapid pacing at 180, and once the cardiac output drops, I will inflate the balloon. Now suppose if I inflate the balloon without doing rapid pacing, the balloon will never remain stable at the aortic annulus and will pump out. So I'm going to pause here, and so if you could see on the hemodynamic screen, if you can see my cursor, this is not VT, this is rapid pacing at 180. And then if you can see at the bottom frame, which is in pink color, is the blood pressure. When I pace at 180, the blood pressure goes down to 50 and the cardiac output decreases. So what happens is that the balloon which is at the level of annulus remains stable. And once I inflate the balloon, the aortic valve opens. And once the balloon is deflated, I would stop pacing and the blood pressure will come up. So that's a very important sign. And now, once that is done, we wait for the blood pressure to recover. However, I would remove the balloon immediately. So this balloon comes out of the body. So and then now you can see on the right lower part of the screen, you can see how the pressure comes back to the normal limits, because now we have stopped rapid pacing and the blood pressure tracing, they gradually come back. So one important thing which you would notice is that in an aortic stenosis patient, if you do continuous or multiple rapid pacing, these patients can sometimes spiral down. So we have to be very careful in doing these rapid pacings, balloon inflations, and then deflation. So this is also an exercise that how the patient would behave when we do a balloon expandable valve. And this also shows us the stability of the temporary pacemaker. So now you can see is uh, the balloon, the valve has already been mounted on the balloon by the therapy development specialist. Before we do a balloon dilatation, we make sure that the valve is fully crimped and ready to go. The reason is, suppose this patient develops any aortic regurgitation during balloon dilatation, we are ready with our valve in order to position. So this is the sheath which is being advanced under fluoroscopy. You would see this very important. So we need to keep looking on the screen and also on fluoroscopy when we are advancing the sheath into the pelvic vessels, because we want to be sure that there is no damage which can happen to the pelvic vessels. So we're going to be advancing the sheath and holding the wire, and we keep looking on fluoroscopy and make sure there is no damage which can happen, which happens to the pelvic vessels. And this is a very gradual process, because sometimes if the artery is very small, as the artery stretches and allows the sheath to go in, the artery can still collapse and stick to the sheath. And the problem is encountered when we are trying to remove the sheath and the artery is stuck to the sheath. And then sometimes there is a pelvic perforation which can happen, and that is called artery on the stick. So once this is done, the sheath is in place. There are multiple ways to do this. Sometimes we would place the sheath up front, and then after putting the sheath, I would go ahead and cross the valve, do a pre-dilatation, and be ready with the balloon, with the valve as we go across. Once that is done, the dilator of the sheath is removed. This is which I was telling you is an expandable sheath through which the valve will be deployed. So if you can see, at all times, I'm focusing on the wire which is there in the LV. That's a very important thing. You saw that wire just came out a little. So we need to be, again, we need to make sure that wire stays in place, and the wire also stays in the cardiac silhouette, and there is no damage which can happen to the LV pericardium. So, you saw a few important steps. One is obtaining the access of the femoral artery. Number two is putting the temporary pacemaker. Number three is taking an aortogram, identifying the correct annular plane. Number four is crossing the aortic valve. Number five is putting a pigtail in the LV. Number six was doing a hemodynamics, measuring the blood pressure difference between the LV and the ascending aorta. Number seven is doing a balloon dilatation. You see that wire comes back again, and I'm going to push it again into the LV. And that's an important thing, because if the wire comes out, we'll have to do the whole exercise again. We'll have to put the pigtail catheter, cross with the straight tip wire, and then do this whole activity again. So it's very important that one person always focus on the wire. And then we did a pre-dilatation of the annulus with an appropriate size balloon. So how do we select the balloon? The right size balloon is equal to or smaller than the short axis of the annulus. So the idea to do a pre-dilatation is to create enough space so that the valve can enter smoothly and there is no struggle which happens at the level of the annulus. Because once you are across the annulus, or you are working the ascending aorta or in the aortic arch, the procedure has to be smooth. If there is too much of push and pull which happens at the level of ascending aorta or at the level of annulus, there's a small possibility that the wire can come out, or the wire can perforate the left ventricle, or a stroke can happen in such patients. So once this is done, then I'll be advancing the valve through the sheath and then into the abdominal aorta. One advantage of using this valve is there is no loading of the valve. The valve is already pre-crimped over a balloon. You need not do any fine adjustments or load the balloon inside uh, the body. So it's already crimped and ready to go. So here you can see the valve is crimped over the balloon, and this is the navigator handle which I had explained to you earlier. So as I'm going across the arch, I'll be flexing and rotating the handle so that the valve is flexes and does not scratches on the outer curve of the aorta. The second person holds the wire carefully because if the wire comes out of the LV, then we'll not be able to perform this procedure. We'll have to do everything again, repeat everything again. So this is very important. What I've done here is I've gone to the LAO view and I'm also looking at the arch as I'm advancing the valve. That's a very important step. So suppose the valve goes and hits the arch and we are not able to advance, you need to pull back, flex it more, and then go in. So don't push the valve if you're finding resistance because that can cause aortic dissection, or it can lift a flap, or it can lift a plaque, which can go embolize to the cerebral vessels and can cause a stroke. Once that is done, I would come back to the deployment angle, the angle at which the annular plane was identified, and I would position my valve as well as bring my pigtail down. So now I need to identify my annular plane. That's very important. You can see the pigtail. If you see, the pigtail is one point on the annulus plane. So what is the annulus for an intervention cardiologist? The annulus is the nadir of all three cusps in a straight line. So what I would do is, here you can see the pigtail is there. The pigtail is there and the valve is positioned in such a way that the middle marker and the second dark band is at the level of annulus. So that's very important. So if you just go by the markers, the valve can sometimes move up and down, and that is because the valve can be moved a little bit over the current balloon. But if the middle marker is at the level of the second dark band, middle of the second dark band is at the level of annulus, it's a good position to begin. Now, even I've started implanting even higher. I'm going by the lower end of the second dark band, especially if I'm using a bigger valve, something like a 27.5 or a 29, or maybe even bigger than that. I would begin at the first light band and above. That is because a bigger valve will have a longer frame. And remember, if you crimp a frame, it will be elongated, and if you expand a crimped frame, it will be foreshortening. So you see, I'm taking so much time to actually position the valve, and we can take this much of time if the patient is hemodynamically stable. So if you can see on the right lower part of the screen, where the EKG and the blood pressure tracings are shown. So EKG is normal, blood pressure is normal, so patient is stable. That means you can take that few extra seconds to make sure the valve is positioned at the correct depth. Because the valve is too deep, patient can have a complete heart block as well as a paravalvular leakage and requiring another valve. If the valve is too high, again, there be a paravalvular leakage and valve embolization. So you see that pigtail is still kept there. Pigtail serves as a landmark for the annulus. If you remember, what was the annulus? Annulus was the nadir of all three cusps, a non-coronary, a right coronary, and left coronary. So here I would keep my pigtail in the non-coronary cusp, which will serve as one of the landmarks. And then once I'm happy with the position, you can see on the right side, if you can see the hemodynamics, this is a very important step. So how you deploy a balloon expandable valve? You do rapid pacing, pace at 180, the blood pressure goes down, and there is a sustained drop in blood pressure. Now suppose if you see here the blood pressure goes down, but all of a sudden the pacemaker stops capturing, the blood pressure will come up to the normal limit, the heart will eject the valve, and we'll have an embolization. So this is very important exercise where you do rapid pacing, the blood pressure goes down and it remains sustained below. Then we begin inflation, then the valve inflates fully, then we deflate, and then only after deflation we would stop pacing. So this is just a test run where you would test your pacemaker. You would pace at 180, the blood pressure goes down, we'll take a picture and then begin a slow inflation. So I'm going to stop here. So if you see, we have started inflating the valve, but you see on the hemodynamic screen, the rapid pacing still continues. The blood pressure is in the 30s and 40s. This is very important. And as I've started inflating the valve, you see a dog bone, which has happened at the proximal end of the balloon and distal end of the balloon. What it does is it makes the valve very stable and prevents the valve embolization or migration of the valve over the balloon. So this is, we're gonna go rapid pacing slowly, and now the valve is fully inflated. Once the valve is fully inflated or fully deployed, I would count 3 seconds by 1001, 1002, 1003. And the reason is you need to give adequate time for the valve frame to come in contact with the annulus and stay there and prevent paravalvular leak. So you see in this patient, once the valve has fully expanded, you give that additional few seconds and the valve is fully in contact with the annulus and the volume which was there in the syringe has been emptied. Then you deflate. So what you can, if you can see, the valve is fully deployed, the balloon is fully deflated, but still we are continuing rapid pacing and the blood pressure is in 20s. So this is very important. Now suppose if you stop pacing and your balloon is still inflated, the LV with a forceful contraction will eject it out. So you stop pacing only after the balloon is fully deflated. So let me show you again here, and we do this rapid pacing, and now you see once the balloon is deflated, then we would stop pacing. You see the blood pressure has come up to around 60 to 70, but what you do is we would immediately remove the balloon. Remember, the balloon which is there in between the leaflets sometimes prevents the coaptation of the leaflets and can cause severe AR. Once the balloon is out, you park the balloon in the ascending aorta and then you wait for the blood pressure to come up. So if you see in this hemodynamic tracing beautifully how the blood pressure starts coming up, and then we do an echo to make sure there is no pericardial effusion. You see how the blood pressure is coming up slowly. And suppose the blood pressure does not come up, you need to look at three things. One is annulus rupture. You need to look at few things. One is annulus rupture, left main occlusion, or pericardial effusion. So, and maybe severe aortic regurgitation. So these things need to be identified if patient is hemodynamically unstable and need to be addressed immediately. However, you can see in these patients, once the valve is fully deployed, the mean gradient is 3 millimeters of mercury. The velocity is 1.23 on the echo on the right side, and there is no paravalvular leak. So that's very important. You need to have a good hemodynamic outcome for a successful transcatheter aortic valve replacement. And now, I think it is hand. The next thing you do is, suppose this patient has any, next thing I would be doing is taking an aortogram. So let us see if there is an aortogram which comes up. Now suppose if there is any aortic regurgitation, and if I need to do a post dilatation, what I would do is I would add few extra cc's to the same system, go inside the valve frame, again do rapid pacing, and then do an inflation. So I'm also looking on the echo if there is any aortic regurgitation. Remember, in such a situation, the aortic regurgitation can be due to the stiff wire, which is still inside the ventricle. So what does the stiff wire do? The stiff wire, again, will not allow the leaflets to come together and close. It might dent one of the leaflets, and these patients can still have significant aortic regurgitation. So here right now, there is an echo evaluation which is going on. And next, but suppose if there is a paravalvular leak, means the leak is from around the valve, and you feel it is significant. The only way to treat such a paravalvular leak is to do a post dilatation. So I would go with the same balloon and add few extra cc's to it and do a post dilatation. So you can see here, let us see what we do here. And before we take an aortogram, but however, you can see the blood pressure on the right lower screen monitor. The ECG is sinus rhythm, so there is no complete heart block, and the blood pressure tracing is normal. So few important complications which can happen in a TAVI patient is complete heart block and paravalvular leak. So you see the complete heart block is not there. Paravalvular leak will evaluate right now. So next step is you remove the parallax and we'll take an aortogram. So you see that is an aortogram. There is no significant regurgitation which is happening. There's no contrast dye which is seen in the LV. So what we did is we injected the dye through the catheter which is there in the ascending aorta. If there is aortic regurgitation, this blood should come back into the ventricle. However, all the blood goes forward. There is some whiff of contrast which comes into the ventricle, and that can be due to the wire. So, in such a heavily calcified anatomy, sometimes we would accept a minimal aortic valve replacement, trivial perivalvular regurgitation, and not do post dilatation because that can increase the chances of annulus rupture. Again, that's an aortogram, and you can just see a whiff of contrast. So what we would do is now we would put a pigtail catheter into the LV over the wire and do a hemodynamic assessment in order to look at the gradient. So when we do these hemodynamic assessments, a few things which we are looking at is one is LV pressure, the aortic pressure, but also the left ventricular and diastolic pressure and the aortic diastolic pressure. Where there is something called AR index, which can be calculated by the hemodynamic tracings, which can tell us about the significance of aortic regurgitation if there is any. So what is AR index? AR index is the difference between the left ventricular difference between aortic diastolic pressure and left ventricular and diastolic pressure divided by the systolic blood pressure into 100. So if the AR index is less than 0.25, there is significant paravalvular leak and it needs to be treated. Multiple ways to treat, either the post dilatation can be done, which is the commonest way, or by putting another valve if the position of the first valve is not correct, and sometimes applying the plugs in order to close that gap between the valve frame and the calcified nodule, if any. Let me just go forward and let us see what we have done here. Now we'll be putting a pigtail catheter. So here you can see you can see a pigtail catheter in the LV, a pigtail catheter in the ascending aorta. And in the right bottom portion, you can see the hemodynamic. You see there is no peak to peak difference. You see the aortic systolic pressure and LV systolic pressure are same. What does that tell us? There's no significant stenosis, and that's a very good result because this patient had high gradients. And you see the aortic diastolic and the LV-EDP, they are away from each other. There's a good difference, which tells us there is no significant aortic regurgitation. Because if there is aortic regurgitation, everybody knows that the aortic diastolic pressure is low. It will come down to the LV-EDP because the valve is freely open and there is significant regurgitation which happens. So this is a very good tracing. And what is AR index? Difference between the aortic diastolic minus the LV-EDP divided by the systolic blood pressure into 100. Less than 0.25, there is significant regurgitation. More than 0.25, there is no significant regurgitation. So again, we would take an aortogram and make sure there is no significant leakage here. Let us see. And then we would also do a pullback. So again, this hemodynamic tracing. And also if you can look at the ECG, ECG is narrow QRS. There is no left bundle branch block, no complete heart block, and there is no other IVCD or intraventricular conduction abnormality. This is a very important step. You cannot complete your TAVR without having hemodynamic. So we do a pullback, the pigtail comes out, and now you can also see on the right side, lower portion, there is no baseline difference between these two pressures. And once we have made sure there is no gradient, no aortic regurgitation, there is no post dilatation required. Then we take a final aortogram by removing the parallax from the valve. These are the steps which are for the education, that how do I make sure that my patient goes home safely and the outcome of TAVR is equivalent to what a surgical aortic valve replacement would give. There are only two Achilles heel at present as paravalvular leak and complete heart block. But in my own experience, the requirement of pacemaker rate is 5.6%. In the Myval study, the pacemaker rate in the first in man 30 patients was not seen in any of the patients. In the first in man 100 patients, there are only 2 patients who received pacemaker. One such patient had a baseline right bundle branch block, and such patients are at high risk. So you can see now I'll be injecting. So you can see, I'll just pause here for For clarification, aortic root. Here is the annulus. This is the transcatheter heart valve which is implanted. And you could see a whiff of contrast. This is the LV. You could see a whiff of contrast which goes inside, and this is called trivial paravalvular leak. And the reason why that trivial paravalvular leak is because of the calcification of the leaflets. However, the trivial paravalvular leak does not affect the long-term outcome, and sometimes it goes away at 6 months of follow-up because of organization. So how do we classify regurgitation? By three ways. We would look at the hemodynamics. Hemodynamics is by AR index. Number two is the echo, and number three is the angiography or the aortogram. In the aortogram, we would use a Seller's classification where 1, 2, 3, 4. 1 is just a whiff of contrast. 2 is the contrast opacifies the LV outflow tract. 3 is the entire LV is opacified but clears in one beat. 4 is the entire LV is opacified but takes more than one beat to clear. And that is called severe aortic regurgitation. A patient cannot leave the cath lab table with 3 or 4 grade 3 or grade 4 aortic regurgitation. It needs to be treated. So this we already saw. Take an aortogram and look at the calcification which is there in this patient. Mitral annular calcification. The coronary arteries are heavily calcified. The right coronary artery is heavily calcified. Such patients are actually extremely high risk for surgery. You can also appreciate a porcelain aorta. So what is a porcelain aorta? If the ascending aorta and arch of the aorta is calcified, surgeons cannot clamp such aorta, and such patients are labeled as inoperable or high risk for surgery. But then now the pigtail comes out, and this is where you can see the valve. But now the most important step starts. What do we do to the hole in the femoral artery? So I presented my data. I don't do any surgical cut down. It is totally percutaneous. There's no surgery involved. I would use ProGlides, which are the percutaneous suture-based closure devices, and do a pre-close. So these are two sutures, knots, and then sometimes use an angio-seal. But that's important because if there's a bleeding which can happen from the femoral vessels, the outcome is poor. Patients who develop pelvic perforation or iliac perforations, again, the outcome is poor. The third thing is patients who have required blood transfusion during transcatheter aortic valve replacement due to any groin or bleeding complications, they have increased chance of infective endocarditis compared to patients who have not received any blood transfusion. So you see in this patient, the wire is advanced, and once that is done, I would remove the sheath and deploy the ProGlide sutures. So as we are pulling out the sheath, here you can see there's a lot of the sheath is taken out, and once the ProGlide is deployed, we would take a picture, DSA, to make sure there is no bleeding which has happened in the pelvic vessel. So that's very important. This is the femoral head, this is common femoral artery, external iliac artery, common iliac artery, and abdominal aorta. So the wire is still there. You can see that wire. The idea to keep the wire in place is that suppose if fix that problem either by putting a covered stent or by taking the help of a vascular surgeon. But thank God, unfortunately, such a thing has not happened. No surgical help has been required pre or post procedure for the pelvic vessels. And then you would see this is how the patient, we would take a final angiogram. This is very important. The final angiogram is very important to make sure there is no bleeding complication which has happened in the pelvic vessels or in the common femoral artery. And also importantly, we need to make sure that there is a good flow distally in the superficial femoral artery. And once this is done, then before the patient leaves the cath lab table, we need to make sure that the patient does not have a stroke, and the patient's neurological assessment is done. So, so the important step for a step-by-step TAVR was to obtaining a femoral access, using a closure device, crossing the valve with a wire, identifying the annular plane, doing a balloon dilatation, advancing the valve in place, positioning the valve at the correct spot, doing a rapid pacing of the heart, deploying the valve. Then post-procedure, very important. We need to assess how the outcome was. If the outcome is good, if there is any problem, we need to fix it, like a paravalvular leak or any tamponade or any annular rupture. The last step is to close the femoral artery successfully so that there is no bleeding and no compromise in the flow to the superficial femoral artery. Um, Thank you very much for attending this step-by-step transcatheter valve replacement. So there is a question which has come up. Can TAVI be done for previously deployed prosthetic valve with infective endocarditis? No, we would not do a TAVR in a patient who has active infective endocarditis. This is very important. The way to treat this patient is to complete the course of infective endocarditis treatment and make sure the patient becomes culture sterile. There is no infection, no vegetation, and then I would do a valve in valve TAVI for such a patient. But suppose if this patient develops infective endocarditis, and because of infective endocarditis, patient develops a mechanical problem like severe AR or an abscess in the root, then this patient needs to be treated by emergency surgery, because the advantage of surgery is the nidus of the infection can be removed. Now, if you do a TAVI in this patient, the nidus would still there and that infection will come up on the valve. The only way to do TAVR is to treat infective endocarditis, document culture negatives, make sure your ESR, CRPs are within the normal limits, and then only do it. You have found it useful. This was just an overview to explain or to show that what are the steps involved in TAVR, so that you all are aware of it. And if there are any detailed uh, discussion or any in-depth questions which you want to ask me, you can write me an email or send me a message on 9116000383, or you can post your questions on this forum and I would be glad to answer your questions. So thank you very much for your kind attention. Are there any further questions? Okay. So if there are no questions, goodbye from my side. And if there are any questions which come up in your mind, feel free to text me or email. Thank you very much.